And my claim to fame here is that I have 35 years of experience in the public mental health system. I've worked in all facets of it, from crisis unit, inpatient ward aid. I've worked in the outpatient clinic. I've worked in the hospital, and I've worked and I've run a psychiatric rehabilitation program. And for 15 years, I've been an advocate for people with psychiatric disabilities. I really appreciate the opportunity to address you. I think the media is critical, has been critical to the success of mental health advocacy, certainly our advocacy in New York and throughout the country. Our groups are disadvantaged. We don't have a lot of money. Your ability to capture our needs and represent them and to right the wrongs that we frequently have to experience has been critical. And certainly, you know, you can just point to Cliff Levy's Pulitzer Prize-winning article, a series of articles that exposed the scandal in the adult homes in New York, or Michael Weinrip, who did the follow-up on Andrew Goldstein and determined that he was indeed trying to get care. Andrew Goldstein was the person who killed Kendra Webdell. So the press, your coverage is critical. I have a disability myself, and I have a diagnosis of bipolar disorder. And many of the people that I work for and work with are people with psychiatric disabilities. That is, people with more major disorders. And in my case, that means I'm going to, under the wrong circumstances, talk too fast, think too fast, act too fast, which is what I really admire about you guys, because you can write real fast. When I'm being interviewed, you can keep up with me. I don't know how you do it, but I really admire it. I want to say a couple of things about, this is a rare opportunity, so I want to make a number of points, because I don't think violence is the real, has been really shown here to be a conclusive sort of factor. A small group with a number of variables. I respect Jeff a lot, but I didn't see any proof that outpatient commitment is really, you know, the way to go. And I want to make a number of other points about that. I have two handouts in the back that hopefully you picked up. One of them is a list of innovative programs that help people with psychiatric disabilities upstream before there are problems and engage them more appropriately. And the other one is some of the material I'll be talking about. I want to say a couple of things about people with psychiatric disabilities, or the mentally ill. The mentally ill is a tough word for us. We're not like, we don't all know each other and have the same thing. We have a variety of conditions. The DSM is huge. Half of you are probably in it. Number two is, contrary to what most people think, people with serious psychiatric disabilities recover, and recovers in substantial ways when given the right mix of services and support. We are a community, as you can imagine. You see how the coverage is. We're written about in demeaning and defaming ways. When I grew up on Long Island and I read Newsday, and mentally ill people, the mentally ill, were referred to in violent ways. African Americans, the only time I read about African Americans was when they committed crimes, and so I thought all African Americans were violent. And the only time the public reads about our community, mainly, is when you have these rare tragedies. And the coverage is extraordinary. According to the Daily News, who is not my friend, 494 murders in New York City last year. 4 to 6 were by people with psychiatric disabilities. You would not guess it by the kind of coverage that the Daily News will put into this. The issue of non-compliance. There are people with psychiatric disabilities who are too sick to know that they need help, and we have to sort of force them into care, because and if we don't, they might get violent. Is sort of the way it's presented. But if you understood what people with psychiatric disabilities have had to face, the services that we've been offered up until recently, and I worked in them all, and I saw how they were delivered. I was in a hospital once, and a couple of years later I worked in one, and the contrast was striking. The low expectations, the infantilization, the overemphasis on medication. And back in those days, we encouraged people to smoke, and we gave them high doses of medications. And now we worry why we're dying 25 years earlier with lung diseases and obesity and diabetes. We help create these these circumstances. The issue for people with psychiatric disabilities is, so we're invited to accept a diagnosis of mental illness. There's a lot of shame and stigma around that. Inevitably, you're told you won't be able to work, so you'll have to be on entitlements. That's a lifetime of poverty. You're going to be put in a program where people will not believe you can recover. We'll tell you, we were tell people, you never have children, don't make too many decisions, don't go too far, don't go anywhere. That's not a prescription for you. You don't want to sign up for that. And I would submit to you that we really ought to be looking at what we're offering people on the street. I don't know, and I know I'm always concerned about the time. So I want to draw your attention to this document here, which basically indicates there's a whole array now across the country of innovative, attractive, engaging services that start with standard practice. If you read any real study of what engages people, it's the relationship, it's starting where the patient is, and it's following up and staying with them. And in many instances, the relationship has been more of a medical, diagnostic, distancing, take your medicine, come back in a couple of weeks, sit in this program. That is no life, no. So why people would want to opt out of that and instead struggle against that is actually a quest for sanity, a quest for health. And we have services now that actually are much more active and engaging. We ought to have many, many more of them. With too much of the focus is on medicine and hospital, and they have their place, but there are so many other approaches that engage the person where they live, that visit the person again and again, that start where the person is, a need for housing, a need for employment, a need for relationship. We don't have a system that's attractive and engaging. We have a system that believes that people can't recover and then holds itself to a low standard of accountability, and that doesn't leave the office. And the rare instances of violence are the tip of an iceberg. Our failure to serve those people and support them sort of appropriately is really the lot of thousands more of peaceful people who are equally failed by that passive, non-responsive, low expectations. Plus, this treatment simply forces people back into the same bad services again, and this over-reliance on medicine and services alone. We really need to talk about a reform. The real story is governments putting the right services on the street in an accountable way, because I hope you've heard that the incidence of violence is small and rare. When you analyze it, there's a failure of service delivery again and again that is the real issue. Thank you.